Good evening, doctors. My name is Rakesh Sonone, and on the behalf of FDC and Med Talks, I would like to welcome you all to the yet another episode of 52 Weeks Diabetic Essential by Dr. Sanjay Karla. And all we know, we have launched a six lecture series on management of topical fever, and we are completed with the two lectures. First is on acute topical fevers, and second is on nursing at home care in fever. And today's lecture topic is topical fevers with rashes. And before going forward, I just want to announce the last week quiz winners. Dr. Gangadhar Rath from Bhubaneswar, Odisha, Dr. Hitesh Vora from Mumbai, Maharashtra, Dr. Rajiv Handa from Delhi, Dr. Sanjay Siora from Surat, Dr. Bharat Mittakola from Surat, Dr. Girish Gesota from Mumbai, Dr. Farid Khimani from Mumbai, Dr. Ramesh Hegde from Bangalore, Dr. G.S. Batra from West Delhi, and Dr. Atul Doshi from Mumbai, Dr. Pradeep Pathade from Vashi, Dr. Sumita Sharma from New Delhi, Dr. Farhan Nurlamin from Kanchipuram, Dr. Sashi Khare from Bhopal, Dr. Ashwini Kumar from Kanpur, Dr. Satish Kumar Jain from Bangalore, Dr. Ajit Kulkarni from Sangamner, Dr. Ravi Bhatt from Sirsi, Dr. Surjit Kalsi from Noida, Dr. Chandrasekhar Mu from HD Karnataka, Dr. Shashikant Shende from Mumbai, Dr. Hemant Adikane from Pauni, Dr. Sanjeev Suri from Hoshiarpur, and Dr. Anand Purandare from Mumbai. And I just want to welcome our today's guest, Dr. Sanjay Karla, President of South Asian Federation of Endocrine Society. And with this, I want to hand over today's lecture to Dr. Sanjay sir. Thank you.
Thank you, Mr. Rakesh, and good evening, everyone. The last two Sundays, we've been talking about fever, tropical fever, and various aspects of fever management. Today, we have an expert with us, a very renowned expert, Dr. Paritosh Baghel. Warm welcome, sir.
Thank you, sir. Thank you so much.
Welcome. Dr. Paritosh is a consultant physician at the prestigious Fortis SL Raheja Hospital in Mumbai. He is ex-professor of medicine. He has taught at the Grant Medical College and Sir J.J. Group of Hospitals in Mumbai. And his academic pedigree, he is an MBBS from Grant Medical College and an MD from KEM Hospital, Mumbai. Not only that, he has ventured into other fields as well, and he is an LLB from Mumbai University and very well known not only as a physician but also as a medical legal expert. Dr. Paritosh, our topic for today is fever with rashes.
Yes.
So why is this topic important, sir? Why rash?
Yes, because, sir, as we live in a tropical country, as we all know, fever is a very common ailment with which people approach us. And rash is many a times an accompaniment to these fevers. And since we have a lot of tropical diseases which we see during, especially in this season of monsoon, so this rash becomes a challenge for the diagnosis. And many times the cause of rash cannot be identified, and also the rash can be pathognomic for a certain disease, so we can easily pick up and identify the disease. So that's why fever with rash is an important thing which one should know about the rash. What are the different types of rash, how to identify them?
So it's about being an astute physician. If you can do a proper inspection, of course, you have to take the history, you have to examine the patient, you have to palpate. But if you can do a proper inspection, that will give you many cues. Sometimes the rash will be part and parcel of the natural history of fever. So it is a syndrome where there's a skin rash and fever together. And based upon what comes first, what comes where, what kind of rash you have, which part of the body, that helps you in diagnosis. Second is that sometimes the rash itself can cause fever. So maybe you have a skin infection, skin and soft tissue infection, which leads to fever. And the opposite is also true. You have an unrelated fever, maybe enteric, and then nobody lets you take a bath. You don't keep good hygiene, and then you end up with a superadded or a secondary skin infection, which can present as a rash. So all different permutations, combinations of it. Sir, last 2 weeks, we have had so many questions on fever, which is actually very welcome. It tells us how interested our doctors are in learning more. And already we have greetings for you from Dr. Ganga and Sana's Makeover, who sends you an Assalamu alaikum.
Thanks. Thank
Yeah.
you, sir.
So, sir, the floor is yours, and we look forward to learning from you. Our topic for today is tropical fevers and rashes.
Thank you, sir. Thank you for the kind introduction and allowing me to speak on this forum. My topic is, as we all know, tropical fevers with rash. So I'm going to talk about what is the importance of rash. When we see a patient with fever and he comes with a rash, what are we supposed to do? How are we supposed to approach the patient? What should be the way we should handle this patient? So rash and its association with fever. So fever is many a times associated with the rash. It is a common presentation. Many a times it is missed because we don't see the rash, but it is definitely seen in various common diseases which we see during this tropical monsoon season. After an insect bite, after so many illnesses, we do see a rash, and these are generally non-specific. And most of the times, viral infections lead to a sort of a rash on the body, which is mainly erythematous. So they are generally non-specific. They may not be associated with any specific disease or so many a times, but it may also be pathognomic for certain diseases. Presence of a rash, the timing, it can help in prompt diagnosis and in the institution of a life-saving therapy if you can identify the rash and you can identify the disease which causes it. Also, one has to remember the rashes may evolve over the course of the disease. They may not remain the same. So the rash which is initially presenting may change over the time period, and it may look differently. So one can make out uh, about the time duration, and one can make out the progression of the disease by looking at the rash itself. Initially it may be vesicular, later on it may become pustular, it may become crusted. So you can identify what stage or what how the course of the disease has evolved, and which stage, whether the patient is infectious, whether the patient is non-infectious. It can also tell you that. Also, it can occur during the course of a systemic disease. So a rash can identify a systemic disease, or it can be identified as a localized disease. Like a rash is present at a localized area. It could be because of cellulitis or something, and you know that this is a local infection. Whereas some rash can be identified with a systemic disease, like in many of the viral illnesses which you get, or many of the other vector-borne diseases. You can have those rash which indicates a systemic disease. And infections, by and large, are the most common causes of the rash. So that's why we are going to talk about tropical fevers and rash. But one should remember that drug reactions, immunological and rheumatological diseases, allergens, and in fact neoplasia also can present with fever and rash. So rash has got an association with fever in various forms. It can represent an infectious disease. It can also represent a drug reaction, an allergic immunological phenomenon, or it can be associated with malignancy as well. How do we classify? If a patient comes to me, how do I identify and how do I classify a rash? Because a rash may come in different forms. And how do I generally classify is on the basis of morphology and the distribution. This is a very important aspect of identification of a rash. So rashes can be classified into as maculopapular, which could be centrally distributed, which are mainly in the truncal area, or they may be peripheral to begin with, like for example in peripheries, in the hands, in the legs. They may present on the basis of morphology. They may look like confluent, desquamative, erythematous reddish rash. They may be vesiculobullous, pustular. They may be like an urticaria-like lesions, which are raised lesions. They may be nodular. They can be classified into as purpuric lesions, where there is bleeding under the skin, or they may be ulcerated or present with eschars, which are crust necrotic areas with a crust. They can also be classified on the basis of appearance, whether they are generalized rash versus a localized rash. As you see in cellulitis, it is localized, but in dengue and other conditions, you would find it to be more of a generalized rash. It can also be classified on the basis of symmetry. There are certain diseases where you get symmetrical rashes, asymmetry. On the basis of causes, most common cause being the infectious cause, but as I told earlier, there are non-infectious causes as well. On the basis of duration, it could be an acute occurrence of the rash, or there may be rash which is persisting for years together. Mainly, fungal infections can cause such kind of rashes where they remain for years together. So first thing, when you see a rash, when a patient presents to us with a rash, the first thing which we see, we take the history and we identify the lesion. That's the first step. Whenever you see a rash, you should identify what is the lesion, what the rash is composed, or the exanthem is composed of what lesions. So these are something which we should know about. Is the lesions can be flat lesions. So the flat lesions which come on the body, where there is, when you touch it, there is no raised, there is no raised structure. It is mainly a discoloration of the skin, and they are called as macules. These are flat lesions defined by an area of changed color. As you can see here, these small areas are macules. And to call it as a macule, it should be less than half a centimeter. And when these macules coalesce with each other, they form a patch. As you can see here, there's a patch which is seen, which is more than 5 mm. So these are flat lesions, whether this is macule or a patch. Next, lesions which you see in the rashes are solid lesions which are raised. They are classified as papules, plaques, nodules, and wheals. Now, what are papules? They are raised solid lesions which are small, less than 5, half a centimeter in diameter. As you can see in this first slide, these are raised solid lesions less than 5 millimeters in diameter. Lesions which are raised and solid and have got a diameter which is more than 5 mm but have a flat plateau-like surface, like as you can see in this picture, these are called as plaques, and they are generally seen in psoriasis. Very common, disease where you commonly see plaques is psoriasis. Nodules are again solid lesions raised which are more than 5 mm in diameter with more rounded configuration. As you can see here, these are nodules which can be seen in various diseases like molluscum contagiosum, infectious diseases, whereas other conditions as well. Wheals, also called as urticaria or hives, can be papules, can be plaques. They are generally pale pink in color, and they appear annular or ring-like. Generally seen in patients with allergic phenomenon, angioedema, urticaria due to allergy, due to dust allergy. It can also be seen with various infectious processes as well. They can be seen in vasculitis, where they last for a longer period of time as compared to non-vasculitic wheals, which are transient. Then there are fluid filled lesions rash. So rashes which have got which are raised, which have got a fluid filled in them, they are generally well circumscribed. Elevated lesions contain fluid. If they are less than 5 millimeters in diameter, then they are called vesicles. As you can see in the first picture, which on the right hand side, these are the vesicles which we see very commonly seen in patients with chickenpox or patients with herpes. Second, if the lesion, the fluid filled lesion is more than 5 mm, as you can see in this bigger, in the second picture, they are called as bullae. They can be seen in various vasculitic things. They can be seen in coalescence of when the vesicles coalesce, they may form a big vesicular structure called as bullae. Pustules are again fluid-filled lesions, but here, when the vesicles and bullae are filled with clear fluid, pustules are raised lesions which contain a purulent exudate. And many of these infections, such as varicella and herpes simplex, they initially start with vesicular type of an eruption. They later on may evolve to pustules. So, as you can see here in acne, you can see these pustules which are there at the lower end of the face. What is purpura? There could be a rash which is purpuric. Purpura is basically a bleeding under the skin. There are two types of purpura, one which is non-palpable, another is palpable. In non-palpable purpura, it's a flat lesion. You cannot feel the lesion on palpation. It's flat. It is mainly due to bleeding into the skin, and if it is less than 3 millimeters in size, it is called petechia. So you have conditions where you develop petechial rashes, or they could be, if it is large, more than 3 mm, it is called as an ecchymosis. So many viral hemorrhagic fevers can lead to this purpuric rash. It could be petechial or it could be an ecchymosis. Palpable purpura, as compared to non-palpable purpura, is a raised lesion. When you touch it, you can feel the purpuric rash, and it is mainly due to the inflammation of the vessel wall. And it is seen in various vasculitic or connective tissue disorders, where because of the vasculitis, the purpura occurs, the bleeding occurs, and it can be easily felt with the touch. Then another type of rash which we see is an ulcer, which is a defect in the skin extending into the upper layer of the dermis. It can be seen with any infective process, like a localized infection because of staph, strepto, where it starts with a furuncle, it starts with a pustule, and later on it gets sloughed up and you find an ulcer. It could be also seen after a trauma. It could be seen in patients with diabetic foot ulcers, which are non-healing. Next lesion which we see is an eschar. It is also called as a tachyonoid. It is a necrotic lesion covered with a black crust. It is very classic for certain diseases which we see in the tropics, tropical fever such as scrub typhus. You can see this eschar, which is very, very common. Also in anthrax, you can see a eschar associated with an ulcer. Other features of the rash which we need to note at the time when the patient presents is look at the configuration. What is a shape? How it is configured? Whether it is symmetrical, annular, target-like lesions. What is the arrangement of the lesions? Is there a clustering of lesions which we generally see in herpes, or it is a generalized rash which could explain measles, rubella? Distribution, whether they are central or peripheral, that also gives a clue to the diagnosis of the underlying disease. Also, the timing of the appearance of the rash in relationship to the fever or the symptoms is also gives you a clue about what are you dealing with. Now, approach to a patient with fever and rash. Most important thing, a complete history must be taken. It is very, very important to understand that most of the patients with tropical fever and rash can be picked up on the basis of a complete detailed history. And what you should include, apart from the common, presenting symptoms and all that, you should also ask about history of recent travel, because many of these infections which are viral borne or which are infectious are can be explained due to a travel to a particular area, traveling to forest area where there's a tick bite and you develop a rash like Rocky Mountain spotted fever or any of the rickettsial diseases. Contact with pets or animals, very common. You have to ask whether there's an exposure to a domestic animal, cat scratch disease and all those things. You should ask about medications, because many a times the rash can be explained because of a drug allergy, exposure to forest and other natural environments where you have been bitten by a mosquito and then you develop dengue or malaria. That is a person who can present with fever and a rash. Exposure to animal or insect bites, recent dietary exposure, whether the patient has changed any diet, because allergic rash can be explained by this. Any history of contact with a sexually transmitted disease. Also immunization status, whether the patient has been immunized, whether he's allergic to any medications, presence of prosthetic material. Along with this, you should also be asking about the underlying status of the patient, like history of diabetes, hypertension, ischemic heart disease, any history of pulmonary tuberculosis, where later on, or any fungal infections. These are very important to get the diagnosis, to reach a diagnosis of a patient with fever and rash. Also, you should look at the site of the onset of the rash, where the rash has started, whether it is peripheral, whether it is central, what about its direction, what about the rate of speed, to identify the disease. Also, you should ask for associated symptoms such as pruritus. Is there any itching? Because intense itching will tell you about something else. Whether there is any presence of swelling, are there any lymph nodes, is there any hepatosplenomegaly? All these things have to be noted in addition to the presenting complaints. This is a simple mnemonic that when you take a history in a patient with fever and rash, what all things you should ask. A very simple mnemonic called as dimples, where you should look at duration, the inciting events, what were the preceding illness, any new medications, topical products, exposure, mitigating or exacerbating factors like any lotions or steroids, or if used any drugs, any relationship to heat, cold, sun exposure, use of chemicals, periodicity, is it constant, is it rising, it is going ahead, it is waxing, waning, what time of the day is the rash, any seasonal variation, location, where was the lesion first noted and how did it spread, what is the evolution, is there a change in the rash with the vesicular turning into pustular, or coalescing, the macules are coalescing, initially it was petechial, now becoming ecchymotic. Symptoms, associated symptoms such as pruritus, pain, bleeding, severity. On a scale, you can ask how bad the pain and pruritus is along with the rash. So this is something which we can easily remember and note down in the history. Also, as I had told earlier, that there is a relationship of appearance of rash with fever. There's a simple mnemonic where you can understand which day the rash comes. Very sick persons must take double tablets. So as you can see here, uh, uh, on the first day of fever, you start developing a rash, which is seen in chickenpox, that is varicella. Second day fever, On the second day, the rash appears in scarlet fever, which is because of streptococci. Third day, smallpox or variola infections. That is, third day, the rash appears in measles, which is common in children. Day four, in patients with scrub typhus or rickettsial pox, the rash appears generally on the fifth day of fever. Dengue, which is very common, what we see is on fifth or sixth day, mainly sixth day, the rash appears and it is sometimes pruritic. It is an erythematous rash, centrally located. Rash in typhoid fever occurs on the seventh day. So you can correlate with the appearance of the rash with the fever and find out what is the probable cause of this fever and what is the underlying disease. So, a thorough physical examination after a history taking, one should look at lymphatic enlargement, look at the abnormal oral, genital, and conjunctival findings, because many a times you might find a rash in the oral cavity as well, where you can see, you can also see Koplik spots, which is pathognomic of measles. Or you should look at the genital and conjunctival findings. Generally, conjunctivitis is associated with viral infections, and many viral infections are associated with the rash. Hepatosplenomegaly can be seen in patients with malaria, other viral illnesses. Presence or absence of tender areas, which will indicate, like for example, erythema nodosum, they are tender, palpable nodules. Stiff neck, neurological findings to understand whether this is some sort of a neurological or an affection of the neurological system because of the virus or because of the bacteria. Early diagnostic testing by sending appropriate samples as per the clinical scenario and the differential diagnosis at hand. Many a times there is no specific investigation to find out, but in any patient with fever and rash in our country, we would definitely be sending for malaria, for dengue, depending on the clinical scenario. Also, many a times the body fluids, for example, if there is a vesicular lesion which is there, and you want to know whether this is a viral eruption, then you can send the fluid, the vesicular fluid, for example, for Zank smear to identify herpes. If many a times the lesions are hard, which you cannot identify with the pattern, skin biopsies is helps in diagnosing. Various serological and PCR based molecular tests can also be used for diagnosis in patients with fever with rash. Remember, by and large, a centrally distributed maculopapular rash, which is truncal, is the most common type of eruption, and it is most commonly seen with viral infections like measles, rubella, various other viruses. Erythematous, pustular, and papular patterns are generally seen in drug-related cases. Many times you may not find any cause, but most of them, which are pustular and papular pattern, are seen with drug-related cases. Severe pruritus is usually associated with drug-related exanthems. It's also some sort of a pruritus can be seen in patients with viral infections and rash. But if there is severe pruritus and associated lab findings which indicate there is eosinophilia, very likelihood that this could be drug-related exanthem. Also, associated symptoms such as sore throat, vomiting, conjunctivitis, cough, upper respiratory infections, by and large indicate a viral infection as a cause of fever and rash. In lab investigations, reactive lymphocytosis indicates a viral exanthem. At the same time, if you find eosinophilia, possibility of a hypersensitivity or drug allergy rash is high on the cards. So I would like to, talk about specific rashes. What are the various, what are the tropical causes, infectious and non-infectious causes of this rash? The maculopapular rash is the most common type of rash in a viral infection, but it can also occur with immune-mediated diseases, drug rash, and systemic bacterial infections. They are classified generally into two groups as centrally distributed maculopapular rash and peripherally distributed rash. As you can see in this picture, this boy has got a rash which has got a distribution which is maculopapular, generally in the truncal distribution, all throughout the abdomen and the chest. And the infectious causes, the most common infectious causes which we see, which cause this kind of a rash, is measles, rubella in childhood, erythema infectiosum, that is fifth disease, roseola, xanthum subitum. Rickettsial diseases such as epidemic and endemic typhus can also present with a maculopapular rash with a truncal distribution. Lyme's disease recently had been in the news. Yes, it is caused by a tick bite, and it causes a rash to begin with, which is increasing in size and followed by a maculopapular distribution associated with arthritis, neurological involvement, cardiac involvement. Erythema marginatum in childhood, acute rheumatic fever is a maculopapular rash, mainly in the trunk. Scarlet fever is a maculopapular rash. Non-infectious causes include connective tissue disorders and various drug eruptions. These are centrally distributed. They begin, they mainly are seen on the trunk or on the torso. Then maculopapular rashes can be peripherally distributed to begin with. The very common and a classical cause, infectious cause, which causes peripherally distributed maculopapular rash is Rocky Mountain spotted fever. Also, secondary syphilis can cause peripheral lesions. These photographs are for Rocky Mountain spotted fever. Chikungunya again, many a times the patient present with a peripherally distributed, mainly on the limbs, and associated findings being involvement of joints, patient having severe joint swelling, joint pain. So you should look for chikungunya. Hand, foot, mouth disease in children, also in adults, generally seen with lesions on the hands, lesion on the legs, associated oral lesions. Erythema multiforme, which can be because of infections, which can be because of malignancy, is also a peripherally distributed rash. Endocarditis, again, you get this rash on the palms, you got those spots, which on the basis of which you can get Osler's nodes, and all those things can point towards an endocarditis. Generally, the rash begins in the acral areas, such as the wrist, palm, soles, before they spread centrally. Confluent desquamative erythematous rash. These are diffuse erythema. The patient comes with you with a diffuse erythema, and during the recovery phase, the skin sloughs off and there's desquamation, generally seen in patients with staphylococcal scalded skin syndrome. It's an emergency. Also seen with drug rash with eosinophilia and systemic symptoms after any drug consumption or reaction to a drug. Also seen in Kawasaki's disease, streptococcal shock syndrome, and scarlet fever. Vesiculobullous pustular rash, very common, and the representative disease for vesicular rash is chickenpox, which is central. Starts on the body. There is a rash which is vesicular, associated with a erythematous base and a halo around it. Whereas localized vesicular rashes are seen in herpes simplex and herpes zoster, where there are vesicles which are clustered around the dermatome. These are the various causes of vesicular rash. It could be bacterial, it could be non-bacterial, such as varicella, herpes zoster, herpes simplex being the very common causes. Other non-infectious causes can also cause these kind of lesions, but in our practice, what we mainly see is mainly these viral infections such as chickenpox, herpes simplex, and herpes zoster. Urticaria like rash, where it is a raised plaque like lesion associated with a lot of itching. Whenever you see a patient with such kind of a rash, an important thing is to ask for history of exposure to an antibiotic, which will tell you that this is probably a drug related rash. Many a times mycoplasma infection is not very commonly found, but yes, if you find a patient who's got mycoplasma, then they can get this kind of a rash. Various viral diseases which can cause urticarial lesions are Lyme disease, enteroviral, adenoviral, and Epstein-Barr viral infection. Also important in this EBV infection is that if there is an exposure to amoxicillin, there is a flare up of the rash, which is very, very pathognomic of an EB viral infection. Non-infectious causes like allergy, vasculitis, malignancy, especially lymphoma, can lead to an urticarial rash. Nodular rash, again, it represents an immunocompromised, in immunocompromised state, it represents disseminated infection. A common, very common and very classical nodular rash is erythema nodosum, which is a rash which appears mainly on the shin area of the lower limbs, where their exquisitely tender nodules are found, generally associated with a systemic disease like tuberculosis or any fungal infection or malignancy. Many a times a chronic disease, tuberculosis being a common reason for erythema nodosum. Also, other conditions which can cause nodular lesions are disseminated candidiasis, where they may have a triad of fever, myalgias, and eruptive nodules over the body. Other conditions, if there is a necrosis of nodules, chances of aspergillosis or fungal infection like mucormycosis are high in such patients. So most of these patients who develop a confluent or a systemic generalized nodular rash are immunocompromised. They would be having some other immunocompromised state leading to this rash. Purpuric rash, petechial rash, or hemorrhagic rash, very common, commonly seen in viral hemorrhagic fevers. As I had pointed this out, petechia are smaller lesions, and purpura is because of the large lesions because the because of the confluence of these lesions. And petechial and purpurary rashes are basically a terminal symptoms in diseases such as meningococcemia. Meningococcal infection is a very common cause for these petechial rashes. Also, various viral hemorrhagic fevers can also lead to this petechial rash, indicates serious illness and needs proactive diagnosis in the early stages followed by treatment. So meningococcemia, again endocarditis, very severe sepsis due to any bacterial cause can lead to a sort of a petechial purpuric rash where the patient goes into a sort of a DIC, disseminated intravascular coagulopathy, and can lead to bleeding under the skin, leading to purpura and petechia and ecchymosis. Ulcerated lesions or rash associated with SRs, and SR is a diagnosis of scrub typhus or rickettsial pox, very very common. But a complete history is very important in patients who come with this. Many a time this SR is missed and it has not been told. So any patient who comes with a rash, look for an SR, especially if the patient is presenting with a non-specific illness, and he's having joint pain, he's having fever, and you find that there's a history of travel to forested areas, possibility of him having a rickettsial disease is very high. So look for an SR. If there is an SR, very much likelihood that this could be a scrub typhus. Also, if there is an ulceration, as I told you in the history, if you ask whether the patient is having any history of occupational exposure to animals, then possibility of developing a tropical infection such as anthrax, cutaneous anthrax, there would be an ulcer on an SR, which may be an only manifestation of that disease. So the differential diagnosis which we get in an acute patient with febrile illness and a rash, this is a simple slide, a chart which tells if there's a rash and shock, possibility of, pneumococcal sepsis or shock syndrome, meningococcemia, staph aureus sepsis, or various hemorrhagic fevers are the common causes. Rash and conjunctivitis in children, very commonly Kawasaki's disease or measles. There could be rash and abdominal pain, is generally seen with scarlet fever, typhoid fever among the infections. Rash and diarrhea, one should look for Vibrio infections, gas gangrene, that is Clostridia, toxic shock syndrome. If there are rash and mental changes, likelihood of meningococcal or typhoid fever, or severe sepsis with staph could be a reason for fever, rash and mental changes. Rash with pulmonary infiltrates, again measles or any infection like mycoplasma, where there could be mycoplasma pneumonia, you can have pulmonary infiltrates. Dengue, severe dengue can have pulmonary infiltrates. Rash and relative bradycardia, very likelihood of typhoid fever. Drug fever is what one should look for. Also, rickettsial infections have got bradycardia along with fever. Rash and lesions of bullae, again look for gas gangrene like Clostridium infections or Vibrio vulnificus. Vibrio vulnificus again seen in patients who have got exposure to sea or water bodies. Rash and purpura, again purpuric rash generally seen with meningococcemia. Other causes could be hypersensitivity vasculitis or cholesterol emboli. Rash and adenopathy, very commonly seen with rubella, where there is post-auricular occipital adenopathy. Among the infectious causes, scarlet fever due to strep can cause adenopathy. Rash and splenomegaly, again look for SLE, look for rubella, look for typhoid fever. This is a simple chart which tells you about the differential diagnosis which you should keep when a patient presents with associated signs and symptoms. Again, so the take home message is a fever with rash can be definitely a challenging thing to diagnose, provided we know what is a rash, what is the type of the rash, what is the character of the rash, what is the association of the rash with the fever, when does it come, how does it go, how is the distribution, what is the spread, and look for associated symptoms such as pruritus, lymphadenopathy, splenomegaly, hepatomegaly. Infectious diseases form the most common causes of the rash, but it can be seen. You have to remember that this rash can be seen in non-infectious conditions like drug fever, malignancy, and other connective tissue diseases as well. Thank you so much.
Thank you, Dr. Paritosh. A very exhaustive discussion. And you've put things in perspective, actually. And so many things you've opened our mind and our eyes to. mind does not know, the eyes do not see. And
Yes, sir.
actually, you've hit the nail on the head, so to say, multiple nails though, on
Thank you, sir.
multiple heads. And now we understand how to go about classifying various fevers. And the simple thing called inspection will help us a lot. Sir, many questions coming up for you. First of
Yes,
all,
sir. Yes, sir.
greetings from Dr. Anshul Singhai from Bhilai and Dr.
Yes.
Gagan Preet. Dr. Nitin Narula also greets you, and we'll take his
Thank you, sir.
question later.
Yes, sir.
Uh, Many of the questions you've actually already answered. Like Dr. Partha Sarthik Krishna Swami said, can you describe the types of rashes for specific diseases? You've done that. Dr. Vishnu Mulchandani asked specifically, where and when does the chickenpox rash appear in the starting?
So the chickenpox rash appears on the trunk to begin with. It is generally on the torso, on the chest, or the abdomen, and then it spreads centrifugally. So it spreads. It starts on the trunk and then spreads to the other parts. It spreads peripherally, and the rash is mainly vesicular to begin with. It's a fluid-filled small lesions associated with a red base, and that starts in the body and then spreads all over. It can, in adults, it can also involve the scalp, and so it's in adults, it's a severe disease. So to answer your question, that where does it start, it generally starts on the trunk. It's a maculopapular rash. Initially it becomes like a macule, and then later on it becomes vesicular, and then it can turn pustular also. Especially in immunocompromised, you will have severe lesions, multiple lesions. In immunocompromised like HIV patients, you may have a pustular presentation as well.
Dr. Girish Vadgaonkar from Dhule in Maharashtra. Thanks you for the discussion. And also another thank you from Maharashtra. This is from Dr. Prakash Jambulkar. One question from Dr. SM Hussain. How do I differentiate between dengue fever rash and measles rash?
Right. So first and foremost, the age of presentation. When we look at it, measles is not so very common in adults,
Right.
whereas in measles is common in children. Because of the immunization programs, the incidence of measles has come down significantly. Not very common in adults, but one should definitely keep patients, females who are pregnant, to be not to be exposed to a child who's got measles. So that is one thing. The presentation of the rash in measles, the rash generally starts in the head, from the hairline, and then it comes down towards the body. And it is a maculopapular rash only. Generally, it is not so very itchy, and the rash, as it progresses further, generally, it becomes clearer, and it is associated with the, as the disease progress, it becomes more and more darker. Also, you will find coplic spots. When you look in the mouth, you would find some erythematous lesion which is there, and the third molar on the cheek, that is there, which is not so seen in dengue. Now, in dengue fever, the also the duration of presentation when the rash comes in measles, as I told you, very sick patients must take double dose. So measles rash is generally appearing on the third or fourth day after the onset of fever. Whereas the dengue rash, when you look at dengue is very common in elderly. Yes, it can be seen in children as well, but elderly. If you find a person who's an elderly who comes with a rash, likelihood of measles is less as compared to dengue. Second, the rash of dengue is erythematous, more of a reddish blanching rash, macular rash, occurring all throughout the body. You can palpate it on the periphery. You can see that blanching rash on the abdomen as well. Associated symptoms such as headache, such as joint pain, is more common in dengue, whereas in measles you will have more of a respiratory involvement, where there could be conjunctivitis, there could be cough, sore throat, which is not so common in dengue. Also, the rash appears on the sixth or seventh day of the illness. It could be mildly pruritic. So these are the main differences between measles rash and dengue rash.
Thank you from Dr. Jagdish in Bangalore as well, in Karnataka. And the heartwarming comment is it's a very good program, fine, but it actually helps me in my practice. So it has helped our patients become better. So thank you, sir. Sir, two questions together. Dr.
Yes, sir.
Piyush Bhimani says, does every person with dengue fever have skin rash? And Dr. Nagaya Naidu from Jupalle says, how common is dengue hemorrhagic fever amongst all patients who have dengue? So
Yeah.
similar questions together.
Yes. So rash may not be present in everyone now. In our color of the skin is pretty. We are brown. So definitely the what do you call the appearance of the rash may not be visible to everyone. If you're a dark skinned person, so you have to have a keen eye for it, because it would be a blanchable rash. You have to press your hand on the skin whether you can blanch the skin. Most of the patients with dengue fever will have some sort of a rash if you look for it. If you're in a dark skinned person, you may probably not see it because it's sort of a vasculitic rash which is seen in dengue. It is mainly because of the inflammation of the small vessels. So yes, you can see in all patients, but you have to pick it up. Second question was how many patients develop dengue hemorrhagic fever? Not very common. It's probably I won't be able to tell you the exact percentage, but I have in my practice of last so many years, and where I have seen lot many patients of dengue. Hardly any patient has, maybe around in my practice of 1 or 2% of patients have gone in dengue hemorrhagic fever and dengue hemorrhagic shock. But majorly, most of the times, dengue fever is a mild disease only.
Yeah. And to be honest, sir, the answer will vary depending upon the kind of practice you have. If you're in
Yes,
primary care, it may be like 1 in 1,000 perhaps,
yes, sir.
because Dr. Paritosh is in a tertiary setup, and then he's saying 1 to 2%, one
Yes,
in a hundred or 2 in 100. So in a
yes, sir.
primary care setup, it will be much less. So do not rush to
Yes,
overdiagnose. That I think the main take home would be that do not overdiagnose. Dr. Bhim Reddy from Hyderabad has this query, and I face it myself as well, Dr. Paritosh. We talk about hydration and nutrition being the pillars of fever management. Don't
yes,
rush towards antibiotics, give good hydration,
yes, sir.
ensure good nutrition, and give symptomatic relief.
Yes,
So
sir.
these would be the three pillars. Now, Dr. Bhim Reddy says, how do I decide when to shift from oral hydration and oral nutrition to intravenous hydration and nutrition?
Yeah. So in any viral illness, so as you know, one should not start antibiotics. First and foremost, it has got no role that is there, and it adds to antimicrobial resistance. So antibiotics, role of antibiotics when you suspect a viral illness is definitely out. Uh, in the initial period of any viral infection, the role of antibiotics is not there. Even if we were to start with antibiotics, whenever there is a risk of superadded bacterial infection, that is a time when you should start antibiotic. That generally happens for 5 or 6 days after the viral infection, when the patient is not improving and his symptoms are not even improving or worsening, or you find that there is a focus of infection which could be probably bacterial, WBC is going up, then possibility of a role of antibiotics is there. Now hydration, very very important in any patient, be it viral fevers or be it any kind of fever, because with fever the metabolic rate increases, the chances of dehydration increase because you lose water because of the fever itself. So hydration, one should look at the individual in terms of when you want to decide when should I give IV, whether the patient is able to take orally well, is he able to tolerate, is there is excessive fluid loss from somewhere, is the patient becoming dehydrated, patient's blood pressure, when you look at the vitals, presence of tachycardia, presence of hypotension, decreased urine output, high grade fever, excessive sweating where the patient is not able to consume water and there is excessive losses. Those are the patients in whom you should consider IV therapy. Otherwise oral rehydration works very well till the time the patient is able to tolerate the fluids orally.
And that partly answers Dr. Bhim's query as well. Now, the choice between, let us say, Enerzal Blitz, Enerzal Zero, that would depend upon the glycemic status of the patient. Dr. Vinay Desai shares a catch 22 situation. Good evening, sir, he says. And he says, patients are unfortunately started on antibiotics from day one. And then you have to do a blood culture after a few days if you are suspecting enteric fever. So, does it make sense to do a blood culture in a person who is already on antibiotics?
Yes, it does, because many a time these antibiotic dosages are not as per the requirement. For example, I see patients receiving doses which are not appropriate for treatment of typhoid fever. That is first thing. Second, whatever the antibiotic you have given, there are you should send a blood culture, even though you don't grow anything, but at least you may be able in some percentage of the patients you might still be able to culture an organism. Also, one should remember there are specific culture bottles which are available. When you know a patient is on antibiotic, you should inform the microbiology lab that I would want to have those bottles which have got resins which will absorb these antibiotic in the sample, and the chances of getting a culture positivity increases. So informing the lab about that the person is already on antibiotics has to be there, so that you get a special culture bottle with resins. But yes, there is still a role in any patient who's not responding to antibiotics to send a culture, because many a times the antibiotic dose is not appropriate, so you may not be completely curing the disease.
That is good information. Do reach out to the local microbiologist, whether in
Yes.
the public setup, in the private setup, and speak with them, and they will get back to you. One of the main reasons why we are not able to manage fever sometimes in the community is lack of crosstalk between ourselves. So now we are speaking with Dr. Paritosh. He's answering our questions so patiently. Uh, if we speak in the same way to the local microbiologist, the local pathologist, they will also help us, and we'll be
Yes.
able to improve our service.
Yes.
Dr. Shami Kumar from Agra in Uttar Pradesh asks the impact of prolonged fever and dehydration on glucose levels in diabetes. Can they rise? Can they fall? Is it both of the above? Can you have false positive because of dehydration? And can you have false low glucose also? Because sometimes the glucose gets converted into ketone bodies. So if you don't do a urine ketone, you will think your patient is very well controlled, while actually patient is slipping into DKA. So, sir,
Yes.
your comments.
Yes, I mean dehydration very much with every temperature rise. 1 degree rise of temperature. There as the temperature rises, the incidence you need to sweat more to bring the temperature down. So obviously the chances of dehydration increase, and if the duration of his fever is more, then the chance of dehydration definitely increases more. At the same time, as what sir said regarding the glucose, I mean one should be aware. I mean, apart from fever, if the oral intake at the same time goes down, the chances of developing hypoglycemia is also there. At the same time, the sepsis itself can cause derangement in the glucose axis, the insulin and the glucose axis, and that would lead to hypo depending on the individual, depending on his underlying status, whether he's diabetic, whether he's cardiovascular disease, whether he's got CKD. All those things will determine the picture whether the patient will be hypo or hyperglycemic. That is what I would say, sir.
Keep an open mind and do look at the urine ketones as well. And if your
Yes.
laboratory is doing urine routine and they're doing a dipstick, tell them to mention ketones in every patient. That way you make less mistakes. Everybody with ketonuria will not have ketoacidosis,
Right.
but certainly everybody with ketonuria must be managed. It might be that the patient drank 1 liter of alcohol last night. It might be that patient is in starvation or patient is dehydrated. So find the etiology and fix it. So urine ketone should be essential. Also, if Dr. Paritosh, would you like to share the names of the exact criteria? If glucose goes down very fast and glucose becomes low, that is actually a poor prognostic sign. It means patient is going into septic syndrome. So,
Yeah.
how does that play out in the ICU when you are managing your patients?
So again, I mean, hypoglycemia is an indicator which indicates poor prognosis overall, be it any infection, be it bacterial sepsis, be it viral sepsis, be it any other infection. So hypoglycemia is something which has got a bad prognosis. At the same time, a patient being hyperglycemic, where the if it is more than 180, 200, the target which you need to keep in any patient who's in the ICU or who's in sepsis is to maintain a blood sugar levels around below 180. That is what it should be. Any hyperglycemia at the same time leads to other complications where the infection itself will not get controlled. That's first. Second thing, it may cause edema. It may cause cerebral edema because of the extravasation of fluid, hyperglycemia related issues such as so all these things, be it hypo or hyper, the target should be that the sugar should not go beyond 180 and the sugar should not go below 80.
This is called the middle path of Lord Buddha,
Yes.
and we also call it the Goldilocks zone. So neither
Yes.
too high nor too low. In general, if there is stress hyperglycemia, it means the adrenal gland is fighting a lot. The adrenal gland has gone into action mode. And if after a few days in chronic ICU or in chronic severe critical illness, chronic critical illness, if the glucose begins to fall, it means the adrenal gland has given up now. That is a poor prognostic
Yes,
sign.
yes,
Adrenal gland is so tired, it is not able to fight the infection anymore. In such cases, you may wish to do a serum cortisol, and ideally that should be followed by a stimulation test with ACTH, which is easily available in India now. And single dose or few small doses of hydrocortisone may help the patient come out.
yeah.
If the
So in
patient has got,
sepsis,
yeah,
yes, sir. So in sepsis, generally we give low dose steroids in the tune of almost 50 milligram TDS QDS. That is what we generally give. That is the
yes.
reason. Yes.
Sir, many more questions if you allow us to take. It is nearly
Please,
10
sir.
p.m. now.
Please, sir. No
Uh,
problem.
Dr. Vishnu Mulchandani asks about pruritus in the elderly occurring only in the evening. Is this a neuropathy or is this a sign of impending fever?
Very unlikely an impending fever if it is coming elderly. I would rather put this that it is mainly related to the skin issue itself, whether excessive dryness of the skin could lead to this. And also one should look at if it is only in the evening, whether there is any exposure to any insects or any dust or something where you have to find out the reason for it. Doesn't appear to be related to fever.
So, Dr. Vishnu, thanks for raising this point. So, take a good history, correct the lifestyle, correct the bathing style, maybe the choice of soap, the choice of bathing linen, what kind of towel is being used, and try to use a good moisturizing cream as well, because the skin does need help. Uh, Again, one question coming from two doctors, and this was from Dr. Sunil Sharma as well as Dr. Sonavane. Which fluids would we prefer in a patient who is admitted with dengue fever?
So again, the most common fluid is the isotonic fluid, which we use in our patients. Very commonly, which is available everywhere, would be normal saline. Use of colloids is what is not recommended even in dengue fever because of the thrombocytopenia, because of derangement in the coagulation parameters, which may, because of the colloid, that may affect. So it's always safe to use crystalloids such as normal saline or ringer lactate in our patients with dengue fever.
And Dr. Vishnu continues with another question. Can herpes affect both upper arms simultaneously?
Now herpes simplex and herpes zoster. So these are two. One is a reactivation, one is a primary infection. So herpes simplex, yes, generally affects the type 1 and type 2, above the diaphragm and below the diaphragm. That is what they say. Herpes simplex affects the upper torso. Yes, in immunocompromised, you can have multiple involvement of various dermatomes in herpes zoster. But herpes can affect both arms. Yeah, I mean possibility is there, but generally we see unilateral affection in herpes. But yes, this can happen in patients with immunocompromised state. I mean, medicine is
Yeah.
such that you may get anything.
But maybe other diagnosis would come up. Simple urticaria,
Yes,
maybe that would come
yes,
on top.
yes, yes, yes.
Or if
So
it is
herpes has to be,
summer,
yes, you are right, absolutely right. So herpes has to be a vesicular region, clustered vesicular lesions. If if it is something else, you should look at it whether there is something else.
with pain also.
Yes. So neuropathy
Maybe
related, if there's, yeah, I'm sorry, sir. I'm sorry, sir.
I was saying miliara, rubra, urticaria, these would be psoriasis, these would be things that you would think of first.
Yes, yes, sir.
And
But the
but
question
Dr.
was very
Vishnu,
particular that can herpes
yeah.
affect both the arms. So,
And but Dr. Vishnu, the question should also include: does the patient have a painful rash or a non-painful rash, a
yes,
pruritic
yes,
rash or a non-pruritic rash? That will help in diagnosis.
yes, sir.
Dr. Paritos, thanks for taking Dr. Sanjay Shehura's question on location of dengue rash. You've mentioned that already. But he has another question. Do you do serotyping for dengue patients in your hospital in tertiary setup?
No, no, sir, we don't. We don't because it's an expensive thing. Plus, it is not done at every place. You have to send the sample in a specified, format and a specified protocol where you have to send it. And generally, in case if there is a huge surge of cases of dengue, and that too with severe dengue, then probably we do send samples to Pune, NIV, but otherwise not as a routine thing. Not as a routine thing. It is only on an epidemiological purpose. The government and all those bodies would be doing it.
And will it impact your treatment in any way? The serotype,
No,
it
sir.
won't impact.
No, sir. It won't.
Role of steroids, you've already mentioned. So, Dr. Vishnu, the steroids will be given when there is adrenal insufficiency.
Yes.
And the adrenal insufficiency is because the adrenal is getting tired, it's getting fatigued. So, we need help. It's called the koala bear syndrome in endocrinology. It's a very poetic, a very nice terminology. Koala bear is that animal which has the maximum homology with the human being's fingerprints. So our fingerprints are closest to those of the koala bear, not to that of the monkey or chimpanzee. However, when we look at the adrenal gland, we have the second heaviest adrenal gland per kg body weight in the entire animal kingdom. The heaviest adrenal glands are with the monkeys, followed by us. And even our adrenal glands are only 3 grams apiece, 3 grams left, 3 grams right. But why we have evolved adrenal gland is because maybe we are always under stress as a species. Monkeys are under even greater stress than us. So we are able to fight stress. We are able to manage. However we do it, we are able to manage. Koala bear does not have adrenal gland. It is vestigial. That is why when koala bears are even put in the zoo in captivity, they don't breed. They just die out. They can't handle even that much stress. And koala bear syndrome is you admit your patient in ICU. First few days, your patient is fighting the disease. Patient is critically ill, medically critically ill in medical ICU. After 3 4 days, you realize that the BP is coming down, the sodium is coming down, the glucose is coming down. No matter what you do, you're not able to get the BP up. You're not able to get the glucose up. That is koala bear syndrome. The adrenal gland has decided to go into koala bear mode.
Right.
So it depends upon the etiology, and of course, Dr. Paritosh is the expert. If you feel that you can support the patient for a week, 2 weeks, 3 weeks, patient will come out. Then we will supplement steroids for all the layers of the adrenal cortex. However, if you feel that it is a terminal case, then you know that the prognosis is poor, and then your counseling with the family members that will take a different track actually. And koala bear syndrome is something that makes it easy for us to understand this physiology and pathology. Sir, comments Jenny Ortega thanking you. Also, a thank you from Ashirwad the tutorial. And one pharmacology question:
Yes.
in chickenpox or in herpes zoster, do you use valcyclovir or famciclovir?
Uh, so now very commonly valcyclovir is an orally available drug, easily available. So valcyclovir is what we have used. Otherwise, we use IV acyclovir. I haven't personally used famcyclovir. My personal use is, I mean, up till now, whatever I have used is acyclovir as an IV formulation, and if I want an oral formulation, it is 1 gram valcyclovir.
So I have also, Mukesh, no experience with famciclovir. As students, we used to use acyclovir, and now in OPD practice, it is valcyclovir.
Valcyclovir.
It's a big tablet, difficult to swallow. I myself have taken it for chickenpox about 10 years ago, and like Dr. Paritosh said, adult chickenpox is something that you would not wish even for your worst enemy. It is a very bad disease to go through.
Yes.
But the number of tablets is less, and the result is faster.
Yes, sir.
Dr. Nitin Narula is doing a great job. Senior Mr. Narula Sahab is 78 years old on sitagliptin, and PPE values are perfect, 180 to 200. So I think at age 78, Nitin, no need to change the medication, and best wishes to Uncle Ji. He's doing a great job of taking care of himself. And on a lighter note, Nitin, you should learn from your dad. Okay. Sir, one last question.
Yes, sir.
This is from Dr. Ashok Sharma. In your practice, sir, many times fever is related to cancer,
Yes.
carcinoma related lung fever. So, just a general viewpoint from your hospital practice. How often is it directly because of the cancer, because of
Uh,
various reactive molecules that are being produced, and how often is it because of infection, superadded
Yeah,
infection?
yeah. So many a times, whenever a patient who's having malignancy or he's under some treatment for it, either surgical or chemotherapeutic agents, and he develops fever. So the first question which comes to our mind whether this is infectious, because nobody wants an infection. Patient is already immunocompromised, and he gets a fever. So first fear is whether he has developed some sort of a infection which is either nosocomial or something which is community acquired. So you have to rule out infectious causes of fever in patients who have malignancy. So after ruling out all those things by doing certain blood cultures, by sending labs, once you rule out that this is not, there's no infectious cause to it, then you have to think about the non-infectious causes. Many a times, lymphoma is one of the major malignancy which causes fever. As you know, these are the type B symptoms which you generally get in lymphoma. So lymphoma, patients with lymphoma, we have seen developing fever uh, commonly as compared to other malignancies. So this is what I see in my practice. And any patient who's having any sort of a chemotherapeutic agents, one should look at it whether any of the drug fever is there. Is there any association of fever with the institution of a particular drug? That you have to see whether the fever comes at the during the institution of the fever. That is what you need to see. Plus, if it is a drug fever, you should look at eosinophilia, presence of any eosinophils in the blood, which will point towards drug-related fever. So this is what my approach is to a patient with fever and malignancy.
And this is to everybody. Do remember that when you have fever with a skin lesion, the skin lesion can be iatrogenic as well. So it can be a
Yes.
drug-induced lesion as well. It can be a fixed
Yes.
dose eruption. It can be an urticaria also.
Yes, sir.
Yeah. Dr. Vinny Hotwani asks, sir, do you use varicella zoster vaccine in your practice?
I have not yet used.
It's
uh, if if you have had chickenpox, and if you are immunocompetent, then very unlikely that you will get a zoster infection. I mean, in elderly immunocompromised patients, yes, there could be some role, but I have personally not used it up till now.
so same answer from my side, Dr. Vinny. But I think emphasis should be on nutrition, immunity building, and for the very elderly, the very compromised, maybe somebody with cancer, for example,
Yes.
or COPD or severe diabetes, then the vaccine should be advised.
Yes, sir.
Last question, sir, from Dr. Meena, and it's a very short question. Let's see
Yeah.
if we can get a short answer. The
Yeah.
best drug for pruritus in a single word,
Any antihistaminic. I would say older antihistaminics are better than
better.
the. Yeah.
But they cause a little bit of
Sleep.
sleepiness, drowsiness.
Yes.
Meena, see what the previous physician has written, and then you change accordingly. Do not
Okay.
hesitate in using the older drugs. So reach out,
Yes.
Dr. Meena, to maybe someone who is senior to Paritosh and me, somebody who's around 60 years old. Ask
Yeah.
them when to use polaramine, when to use Atrex, drugs like that, and
Yes.
when to use Avil, and you will get a lot of insights just sitting with those gurus. So
Yes.
that will help you overcome this. It will help you fulfill that, overcome that need gap. So what Dr. Meena is actually saying is, of course, she knows how to use cetrizine and she knows how to use fexofenadine. But the point is, the people who don't respond to that, what do we do? So best
Yeah.
would be to catch hold of a senior physician who will be very, very happy to share his or her expertise with you.
Yes.
So I'd like to thank everyone. And last comment is from Dr. Manu Sharma, who is the leading physician of New Delhi. He says, "Good evening, sir." So good evening, Manu. It's good night now, and very informative talk. Thanks, Manu. Your ears are kind to us. Thanks, Dr. Meena, as well, for your patience. It's not easy to take time out from the family and join us on a Sunday evening. I'd like to thank everyone who has been part of today's show. The word fever itself creates a lot of heat, and all these questions are very welcome. I'll take one question from Dr. Sanjay. Post-herpetic neuralgia, whatever you are comfortable with, I prefer oxcarbamazepine. You can use amitriptyline as well. So, Sanjay, what I would suggest is you begin using one drug, which might be amitriptyline, which might be oxcarbamazepine. If you're afraid of using these, try gabapentin. Begin with small dose, maybe gabapentin 100 also, if you've never prescribed in your life before. Then you go up to 300, or pregabalin 50, and then you go up to 75. Begin with a single drug. If patient is unhappy after 2 or 3 days, you can always add a second drug. And for immediate pain relief, you will need a centrally acting or a opioid or non-opioid analgesic. Tramadol, Dr. Paritosh, we have a challenge here in Punjab and Haryana. The rules are strict, which are welcome, but our
Okay, sir.
chemists are not willing to stock the drugs now.
Oh,
So we are having to use non-opioid centrally acting
analgesics.
analgesics like
Right, sir.
Nifosar and like
Yes.
flupetine,
Yeah. Flupentazine.
because of the lack of availability of the drugs like tramadol or
Right, sir.
tapentadol.
Right, sir.
I'd like to thank everyone who has been with us more than an hour, and we can continue going on and on. The questions keep on pouring in, but like it was introduced in the beginning. This is a 6 to 8 week long series, and we hope to have you back with us, everyone back with us next week for another discussion on fever, on tropical
Yes.
fever.
Yes.
Dr. Paritosh, speaking about fever, does that increase your temperature or does it relax you as a physician? Teaching about
Yeah,
fever,
I mean,
learning so many things from our
yeah.
from
Sir, again, I
being
mean, fever. I mean, we feel that in it's such a simple symptom, fever. I'm sick every time you get it, but it can be sometimes very challenging because managing fever if the patient if you're not getting any diagnosis like management of pyrexia of unknown origin where you have done everything and you are not able to uh, find out. And also I recently have a patient who's admitted with me right now, sir, is a 70-year-old gentleman. I would just like to share for a minute that he's been admitted with he came with the fluid overload state detected to have CKD, diabetic, hypertensive, was breathless. Once he became a little dry, he still started getting some sort of a chest discomfort in the night, and it was looking more like an angina. So we did investigate him. We did an angio, and on an angio he got a proximal LAD lesion, tight lesion, 99, 98% RCA lesion. So he's like a ticking time bomb. And we had planned that he should go for the procedure, and then he started getting fever, and it's been almost 12 days, and we have not yet found the cause of fever. Multiple sets of blood cultures sent, urine cultures sent, all the lines whatever he had, we removed it. And finally, after around 10 or 12 days, we were up till now giving empirical antibiotics, looking at the counts and looking at the CRP values and all that. Fever not settling. Finally, we got an organism in the urine, which was a carbapenemase resistant enterobacteria. And now, even after those higher antibiotics, the fever is not resolving. And we are just, so fever can be this challenging, where it may be an innocuous thing where you may find taking a paracetamol just takes away the fever. But at times, fever can be so challenging that you feel helpless that what to do next.
but now we are not helpless. Thanks, Dr. Paritosh, for empowering us and for
Thank
helping
you,
us.
sir.
And we look forward to having you again on the show
Thank you,
because we
sir.
learned so much from your experience, from your
It
insight.
would be my pleasure, sir. It would be my pleasure. Wonderful series you have made, sir. It's a wonderful series, sir.
Thanks is actually due to Team FDC led by Mr. Anang Basu and ably supported by Mr. Rakesh and Mr. Ankur. They are the ones who keep this going. And I'd like to hand over to Ankur before we conclude for today.
Thank you so much, sir, for your kind words, sir. Now, I would like to thank Dr. Sanjay and Dr. Paritosh for giving such engaging, informative, and important topic that we have taken this week. And your expertise and insights were valuable for all of us. And thank you, sir, for your time. And next week, that we will again come up with one more topic on our topical fever series. So looking forward to have our whole audience with us again. So thank you so much. Jai Hind.
Thank
Jai
you,
Hind.
sir. Thank you so much. Jai Hind.